It's been a pleasure to be the chair of the Medical Advisory Board for 4 years. It's a 3-year term. Only somebody from Washington could pull that off. But so we're going to have a change in the head of the Medical Advisory Board. And we're just very fortunate in this group that the neurosurgeons around the country are able to serve and are willing to serve on the Medical Advisory Board. And I know that we'll continue to add very good Medical Advisory Board members, as well as whoever the new chair is. I'm sure that he'll be a great advocate for the group. But I was asked to speak on Syringomyelia, and we treat Syringomyelia at the Clinical Center of the National Institutes of Health, and that's shown here. That's where I work. My office is back here, but this is where the patients go. We have a lot of security, which is sort of a turnoff for patients. Oh, I have it here. Yeah. But I'm going to start basic. The Parkers used to come in and they would just like put their hands over their head, you know, because they've been to like 20 of these talks. But other people, I'm going to start from scratch, and then we'll get more and more complex. So if you've been to a lot of these meetings, it will get more difficult. Okay, so Syringomyelia, Syringo in Greek means syrinx, and myelia means myelos, or spinal cord. So you put those together, and it's an abnormal cavity filled with fluid in the center of the spinal cord. And the big thing is the syrinx distends the spinal cord. It makes it bigger. And the problem with the distension is that distension injures the inside part of the spinal cord. Now you have the processing part of the spinal cord called gray matter, and then you have the transmitting part of the spinal cord, which is white matter. And if you injure, and this is like a butterfly, that's the gray matter. If you injure the gray matter, you interfere with the nerves that go out to the arms and move your arms. So your arms get weak, and you lose the muscle mass because the muscles need the nerves to keep them stimulated to maintain their bulk. You also need those nerves for pain and temperature sensation. So if you have a syrinx, a lot of people have loss of the pain and temperature sensation. And some of that is because the syrinx goes back here where some of those nerves start. And the other thing is, some of it's because the nerves have to cross over and the syrinx is knocked off that crossing over point. And people with spinal cord injury usually say, well, they're paralyzed from here down. But for a syrinx patient, it's not like that. It's suspended. In other words, they're numb in one area of the body, and they can have perfectly normal sensation below that. So they say, my hands are numb, and they describe this as a shawl, when people used to wear shawls, shawl distribution. And the same distribution could be the area of intense pain. Some patients with Syringomyelia have what's called neuropathic pain. So that's the gray matter. But the syrinx also stretches the white matter, and what that does is these are the nerves that are passing down to the part of the spinal cord that moves the legs. And you get spasticity, which is a stiffness and poor control of the muscles. In other words, the nerves that control the lower extremities are interfered with, even though the syrinx is up in the neck. All right, so Syringomyelia usually develops from an underlying condition. In other words, it's uncommon for people just to have a syrinx and not have an underlying cause. And most of the time, the cause is Chiari 1 malformation, about 70%. Basilar invagination, a few people have that, but the next highest cause of Syringomyelia is a lesion within the subarachnoid space. That could be somebody who's had trauma, they could have a cyst, they could have deformity of the spinal cord. And that's the other type of Syringomyelia that Dr. Iskandar showed. So all the patients at the clinical center are in clinical trials. So we treat them all in a certain way, and we pretty much define what we're going to do before we start each study. So in these patients who are in a trial for Chiari and Syringomyelia, the 28 28 patients. These are some of the symptoms they have. So if you have Chiari Syringomyelia, you're going to have symptoms related to the Chiari, like headache at rest, headache with coughing, maybe some ataxia, which is just unsteadiness walking. And then you'll have some problems related to your Syrinx, like sensory loss, weakness, and when we examine the patients, almost all the patients will have some sensory loss, whereas fewer patients will have weakness and trouble walking. So why treat syringomyelia? Well, this is a tough question. It has to be individualized. It's not like everyone with syringomyelia has generic syringomyelia and we just have a knee-jerk reaction. We treat them all the same way. You can't really do that. Some people have little syrinxes, not associated with anything, and they're perfectly fine, and they just got a scan. Those don't need to be treated. You need to treat syrinxes in patients who are getting worse, or if they didn't have anything in the first place, they start developing something, particularly when it's associated with a Chiari malformation or a cyst or some problem in the spinal canal. If one of these syrinxes is growing, it's also already shown that it can cause weakness, numbness, chronic pain. If you don't treat it, the syrinx can grow and can have an effect on the spinal cord, as I showed before, and you can have even more loss of sensation and strength. But this is all, you may be able to predict how people will do based on how they have been doing. If somebody just has pain but no problem on examination and the syrinx is extremely small, the patient might decide not to have surgery, and I couldn't say that's a bad decision. But in Chiari Syringomyelia, we know that patients tend to get worse. So if they have a neurologic deficit and it seems like it's getting worse, this type of syringomyelia should be treated. And even back in the 1990s, the success rate for decompression is about 80%. And I'll go into decompression. I'll show you some pictures of that. Around then, in the 1990s, people said, well, more is better. Why don't we do a decompression and a shunt? And what they found out was that because of the problems with the shunts, people actually did worse. So that's why you say, well, I've got a cyst in my spinal cord and you're operating up here. What's going on? Well, with a Chiari Syringomyelia, the problem comes from the tightness at the base of the skull, and if you relieve that, the syrinx will go away. All right, so the operation has some small variations, but so with the study that was reported earlier, you cut in the back of the head and upper neck, and you remove some bone. And that's, if you get that far, then you're the first group in this study Dr. Iskandar was reporting. If you get this, if you open the dura, then you get to the next stage. And if you opened what's called the arachnoid, the next layer, and then you operated on the tonsils, that would be the third stage. And if you do open the dura, you have to close it, and people put patches in. And we take our patch from up here, but you can buy material for patching too, and that seems to work. So from a surgeon's perspective, what we do is we remove the bone, we open the arachnoid, and then we put the patch on. Somebody asked me for some pictures of the operating room, and it was like for Family Circle, and I bought them pictures like this, and they say, look, people aren't going to want to look at that on Sunday morning, you know, with their bagel and coffee, you know, so I had to give them pictures of like people scrubbed in the operating room. During surgery, we take the bone off, and you can do an ultrasound. And the dura, this is that membrane here. This is the syrinx. You can see the syrinx if it goes up high enough to the base of the skull. And here's the spinal fluid, and here are the tonsils. But you can see across here, this black stuff is spinal fluid. There's no spinal fluid, and that seems to be a critical problem with Chiari. Just like if you have a lesion or a tightness in the spinal canal, you can get a syrinx from that. You can get a problem from that tightness at the base of the skull, and that will cause syringomyelia. Let me see. And what we see at surgery is, though all the MRI scans show the brain static or not moving, the ultrasound lets you see things in real time. And well, I think we're done. Let's see, try it again. Well, maybe we'll try it again. But anyways, somehow I figured out how to get, okay. So see, every time the heart beats, the syrinx also pulsates, and this is more dramatic than in a lot of cases. But it seems like it's not just a problem of looking at the MRI and the brain looks like it's not moving. The brain actually does move, and it seems like the pulsation of the brain and some enlarged pressure waves have something to do with the development of syringomyelia. Okay. Now this is another movie. So this is after the bone's removed, and then we just cut the dura, and you can see through the arachnoid, you can see the brain pulsating. So see how the brain pulsates, and this is with the arachnoid intact, and here's with the arachnoid. But so you see, it's not a static process. Every time the heart beats, the brain pulsates, and that causes what we think a sort of a piston effect, which causes enlarged waves that have something to do with syrinx development. So in this study, it seemed like the surgery was very effective. Syrinx gets smaller just with the decompression. They get shorter, and the tonsils round up. Because it's so tight at the base of the skull, if you give the part of the cerebellum that's pinched, the cerebellar tonsils, if you give them more room, they'll take a normal shape even. So it's not a congenital abnormality of the brain, but really it's just an abnormality caused by there not being enough space in the back of the head. All right, so the long-term outcome of this surgery, because we tested everybody carefully before surgery and after surgery, found, well, the surgery is quite effective for relieving headache related to Chiari. However, when we looked at other things like sensory loss by exam, most people who had sensory loss or some numbness before surgery, they had it after surgery. If they might be able to walk just a little bit better after surgery, and their weakness was a little bit better. But the problem with syringomyelia is once you lose some of your function, it's hard to get it back. So you might get a little bit of function back, but you won't become normal. So as far as this operation, it's very good for relieving the headache, might improve symptoms from that part of the cerebellum being pinched, or if the brainstem was involved. And for syringomyelia, it might improve a little bit in your symptoms, but the main reason for doing the surgery is to prevent you from getting worse. And on the MRI, what we look for after surgery, we look for the space. Here, see, it's really tight. There's none of this black signal, which is fluid, cerebrospinal fluid. It's very tight at the foramen magnum. But we look for a space at the foramen magnum, and we look for the syrinx to go away. And as I said before, the tonsils go from being really stretched, and they round up after surgery. Because we've created, this is where the bone edge was before, we've created that much space behind the tonsils. You know, you have to be careful when you use tonsils as a physician. I said the other day, well, we're going to decompress the tonsils. And I come out, and this woman says, well, this is my friend, she's a nurse. So I come out, and she said, oh, really? How did you get through, through the mouth to take care of that? And I said, no, there were cerebellar tonsils. I said, what did you do, move them out of the way? Okay, but anyway, she says, well, where was the dressing anyways? No, I said, no, we operated on the back. Okay, but well, that was my fault. All right, I should have explained it better. So anyways, what we try to achieve after surgery is to a normal type of state where the spinal fluid, every time the brain pulsates, can move across the foramen magnum. So how long does it take for the syrinx to go away? Well, we looked at that, and we always show our good cases. So this patient had a syrinx before surgery. A week after surgery, it was a little smaller. 3 months after surgery, smaller still. But in general, for the syrinx to become about less than half its original diameter, it takes about 3 to 6 months. But if the ventricles are a little bit enlarged, even though they don't have hydrocephalus, it can take longer. And in one patient, it took 3 years. I suggested reoperation for the patient. He said, well, why should I have that? I'm feeling better. So he was right. So, but it took a long time for his syrinx to go away. Sometimes things don't work out. We studied 16 patients. One was from the NIH, one was my patient, and 15 from outside that failed surgery. This patient had a syrinx. You can see that black area in the spinal cord. And then a year later, was getting worse, and the syrinx didn't go away, but it looks like a nice decompression. But we thought we would study her as well as the other people. And if you fail surgery, you have almost all the same symptoms and signs that you would if you never had surgery in the first place, but you're a little bit worse because you've had the disease longer without being treated. And so here's another example. It's the bone's removed, but there's no space. There's none of the black fluid behind the cerebellar tonsils. The only place the fluid is in the middle of the spinal cord because the syrinx is still there. Here's another patient. You could see that whereas normally you have this black signal, which is fluid at the foramen magnum, here it's just tight. It's all brain and spinal cord there. I don't have to get into that. And what we found, the reason that the previous surgery didn't work is that the fluid spaces weren't enlarged. And these were the reasons: not enough bone removed, and this is scarring, and this is a cyst formation. So those were the causes for the surgery not working. But in all but one case, we could take care of that, and the syrinx would become smaller. The person that it didn't work on had so much scarring that we weren't able to recreate a CSF space across the foramen magnum. And this patient I started out with, I showed you this little cyst. What this cyst was is all the fluid was outside the dura, and it didn't communicate. So what we did is we opened this up and created a larger space. So here you can see that there's fluid behind the tonsils, and then the syrinx became much smaller. All right, I'd like to talk about another type of syringomyelia. This is a primary spinal syringomyelia. It has a crazy name. Dr. Ulrich Badstorff, who's an emeritus on our medical advisory board, named it that. It's a crazy name, but I can't come up with one any better, so I think we should just call it primary spinal syringomyelia. It's it's primary because the syrinx is caused by a condition in the spinal canal, not the Chiari malformation. And it can come after trauma. You can have post-traumatic syringomyelia, or it can come from scarring, or from cyst formations, or you could have meningitis before. And we like to treat it by doing a laminectomy, taking off a little bit of bone here, and then taking out a problem that's pressing on the spinal cord or blocking the spinal fluid pathways, like the cyst here. But if you have a lot of scarring that goes way up and down, you can't do one operation to take care of that. And those people need shunts. And that's why we call shunting the last resort. It's better to treat the underlying condition rather than a secondary condition, which is syrinx developed from something in the first place. So we like to treat what causes syrinx. And if we can't, then as a last resort, we'll treat the syrinx itself. So we had 36 people with post or primary spinal syringomyelia, and about half of them had trauma. And so, some of them had what they thought were causes of the syringomyelia, but 14 had no previous events. Some of the people had previous spinal surgery, and some had syringomyelia surgery. And all of them had sensory loss. Most of them had weakness. A lot of them had bad pain. So this is generally not as good as having Chiari Syringomyelia. Syrinxes are as large, and but a little bit shorter in general than with Chiari. And here's an example of having a cyst. You can see this is a myelogram. You can see the dye coming down, and right here you see the step off, and that's where the band would be. And that band caused, and this is the MRI scan, this band caused the syrinx in here. So just like in Chiari surgery, if you do ultrasound during surgery, these syrinxes pulsate too. They might not pulsate in the whole syrinx, they might pulsate in the syrinx above the block, but they do pulsate. And they pulsate in a strange way. Say there's fluid that's coming down in a channel here, and then you have an adhesion here, and there's fluids coming in this pathway, but not in this pathway. So this is an example of a partial block of the spinal canal. So this is the clinical outcome for the group as a whole, and it seemed like people did pretty well. But you can show statistics to come up with any conclusion you want, but this is a more telling result, and that is 28 patients did well, which meant their disease was stabilized. And so as surgeons, we were humble, we have humility about this, but this is the part that, these are the people we really focus on, because these people had poor outcomes. I didn't help them at all. And because in the group that did benefit, their syrinxes became smaller, but the patients who didn't benefit, the syrinx didn't get any smaller, didn't get any shorter. And when we measured pressure transmission, it didn't improve at all. So, but in about 7 out of 9 cases, you'll have a good result. And now, after doing this study, I'm a little bit smarter, and I could pick out the people who won't do well with the laminectomy, Duraplasty, and those people I would go to a shunt with. So, but this patient had trauma when he was young. He had paraplegia, but then he worked on the computer, and he started having clumsiness of the hands. And you could see he was paraplegic from this, was in a wheelchair, but he couldn't use his hands because of the syrinx. And what we did is we decompressed the scarring at the level of his trauma, and the syrinx went away completely. But as I said, not everybody gets that result. The man I showed you to start with, the scan, who had the cyst, we took that out. Here's the spinal cord. And then we did a Duraplasty. This is what's called a Duraplasty, sewing in this graft here. And you can see that the fluid was blocked front and back before surgery, and he had flow of fluid after surgery. And his syrinx, which was here before surgery, went away completely on what's called the T1, but you could see that there's, on the T2, it went away, but there's still little remnants showing you that it was there before. So with this type of syringomyelia, we try to do the laminectomy and Duraplasty, because you can attack the underlying problem that causes syringomyelia if there's just a lot of scarring that extends up and down the spine. This won't work, so you need to try to drain the syrinx with a shunt. So with our studies, we think that the cause of syringomyelia, and other people have pointed this out too, the cause of syringomyelia is a block in the spinal fluid pathway someplace, either at the base of the skull, at the foramen magnum, right there, or within the spine. And the key to treatment of syringomyelia, if you can, is to relieve the obstruction. So we've had a lot of people work on these studies over the years, and thank goodness, because it's a lot of work. And we've completed these studies. We have a genetic study ongoing, but we're analyzing data. It's very, very difficult. It's very frustrating. And then hopefully the geneticists can shed some light on this. And we have a natural history study, which is we just take anybody with syringomyelia or people who have Chiari, and then we follow them for 5 years. We get a scan every year. And the people who need surgery, we tell them we recommend surgery. Some people say, okay, I'll go for it. Other people say, well, I'm in the study. I just want to see what will happen. So we say, well, we don't agree with that, but if you want to, we'll watch you in the study. We'll see how you do. And the intent of the study is to see how some types of syringomyelia, say syringomyelia without a Chiari malformation or without primary spinal syringomyelia without any neurologic problems other than maybe a little pain here or there, how those people will do over time, because they might do just as well without surgery, some people, than with surgery. So we're comparing how people do with and without surgery, and we also, as with a lot of other studies that are ongoing now, we look at how people do as far as quality of life and their function, because that's very important for patients. So thank you for your attention, and thank you for inviting me. I think this is probably, I've been with ASAP on and off for 20 years, so you'll be tired of inviting me after this, I'm sure. So thank you very much.